I'd like to start by defining the terms a little bit. As Jason said, we're talking about why assisted suicide is suicide. Now, you may have seen proponent attempts to call this death with dignity, or most recently, aid in dying, and we call it assisted suicide. The practice is that a patient can go to the doctor, ask for a prescription of lethal drugs that they can then overdose on to end their own life. That is suicide. Now, aid in dying, frankly, is far too broad to be a helpful term. There are many people, many of us in this room, and many of our loved ones, I'm sure, who have needed aid in the dying process. There's a reason that we have palliative care and hospice care. Those provide aid to people who are dying. Similarly, aid in dying is used in Canada, on the other end, to talk about euthanasia, which is where the doctor actively injects the patient with lethal drugs to end their life. So when we're talking about our terminology, we need to make sure that we're being accurate about what we're talking about. The policy being put forward in New York is assisted suicide, where a patient ends their own life with the help of the doctor and the sanction of the state. So I'll back up a little bit, tell you about PRAF. I work for Patients' Rights Action Fund. We are a single-issue organization. We are non-sectarian. We are nonpartisan. The only thing that we do is work on this issue. I am very fun at parties. So we're existing in a space where we get to work with our wonderful conservative allies, like all of you, and we also work with our progressive allies and with disability rights activists. This is a really interesting issue that doesn't cut across those traditional blue and red lines. If it did, we wouldn't have been fighting this for 10 years in New York. It would have passed already here and in Massachusetts and in Illinois and in Maryland and in Minnesota and in all of the other states that they've been trying to push this in for the last 30 years. And this has been going on for 30 years. But it hasn't passed in those states. In fact, no new state has enacted in almost 4 years at this point. And that's because this is not a strictly partisan issue. This is a human issue that we all come at with very personal stories and personal feelings about what death does and what death should look like. I said about 30 years, so 1994 is when Oregon first passed a ballot measure that approved the act of assisted suicide. It was enacted in 1997. There were a lot of court challenges that held it up, but it did go into effect in 97. So we have almost 30 years of data now that I don't have to stand up here and tell you there might be a slippery slope, things might be dangerous, things might be discriminatory. I can point you to the Department of Health from Oregon, and we can see exactly what is happening, we can see exactly why it's dangerous, and we can see exactly why it has no place in New York. So I'll start with my background. As Jason said, I'm a social worker with a background in gerontology. And before I started this job, I was working in the local college system at SUNY Schenectady and at Hudson Valley Community College, running a program for students who have disabilities. And it's interesting what you learn when you're in that kind of a role. And as I'm sure many of you have experienced, if you have a loved one with a disability, the work that you have to do to get the adequate care and the adequate support is just kind of unfathomable until you're there, frankly. You know, I had a student who we'd had a snowstorm. We live in New York. Of course we had a snowstorm. And the next day she couldn't get to class because she uses a walker, and they had shoveled the stairs and they didn't shovel the accessible walkway. I know, exactly. So, you know, I think about these stories when I hear about the people who are most vulnerable to these sorts of policies, and when I think about the reasons, according again to the Department of Health in Oregon, that people are seeking this kind of law. So let me ask you by a show of hands, how many of you would think that when someone goes to their doctor in search of lethal drugs to end their life, that they are doing so because of pain and suffering? All right, some hands, right? It's a reasonable assumption. So would it surprise you if, again, according to the Department of Health, patients do not self-report pain or fear of pain as one of the top 5 reasons that they're requesting these drugs? Never in almost 30 years has it been a top 5 reason that people are requesting these drugs. They request these drugs because they don't want to be a burden on their friends and family. They request these drugs because they feel as though they cannot participate in life the same way that they used to, which is a natural thing to feel when you're facing down a terminal illness and when life changes because of disability or illness. These are reasons that if I went to the doctor and I said, I feel as though I want to end my life because I'm a burden on the people around me, my doctor would direct me to appropriate mental health care. But if I had a terminal illness, my doctor could write me a prescription for lethal drugs and say, I understand, that is a valid reason to die. Let me help you. So according, again, to the state of Oregon, this is why people are seeking out these drugs. People also self-report financial implications of treatment as a reason that they're requesting lethal drugs. The cost of treatment would be too high, or perhaps they don't want to leave their friends and their family with medical bills when they pass, and they think it would be better for the people around me if I was gone. That is a very dangerous thing for the state and for our society, to look at someone when they say that and to agree with them. Because when that becomes your criteria, that it's okay for the state to help you end your life because you feel like a burden or because you're experiencing disability, there really is no end point. And we see that in Canada. We see that in every other country that has legalized this. Australia, which has somewhat similar safeguards, quote unquote, to what we have here in the US. There was a frankly dystopian news story earlier this year, a few months ago, where a man was in the hospital waiting for in-home services, and he had been waiting for in-home services, and he had been waiting for in-home services, and they just weren't coming. And he said, it's better for me to die than continue waiting for these services. I am out of hope. And he was calmly interviewed by a reporter next to his hospital bed as he expressed that. What a thing for us to say to our most vulnerable neighbors and our most vulnerable loved ones. So I'll back up, tell you a little bit more about how I come to this issue. I come to this issue as the daughter of a mother who had stage 4 ovarian cancer and was diagnosed with 6 months or less to live in the state of Oregon, where I grew up. So what happens when you're a patient and when you're a patient advocate in a state where this is legal, where the background noise of what healthcare is has changed? And one of the doctors in her oncology practice was an outspoken advocate of the assisted suicide law in Oregon. He was one of the few who had been in the news and talked about his support of it and had really been instrumental in helping it get passed. So when that's your doctor, you have to wonder what they think about you and your quality of life when your diagnosis qualifies you for this law. And if you go to that doctor, how are they going to look at you and provide you the best quality care when in the next breath they would write you a prescription for lethal drugs if you asked? And you might say, okay, but Jessica, that would never happen because this doctor knows you and they know that you're not in the condition, these hard cases that we hear about and that we think about and that our minds go to when we think about who's using this law. So I'm going to tell you a little bit more about what we know from the Oregon report. The majority of doctors don't want to kill their patients. Thankfully, that's good news. The majority of doctors don't want to write these prescriptions, even if they support the legality of it. They support the philosophy of it for some patients. They themselves don't want to be involved. So what we see in Oregon is that the majority of doctors that participate in this maybe write 1 or 2 prescriptions. In 2023, one doctor wrote 76 prescriptions. It's an awful lot. I'm not a mathematician. I picked social work for a reason, but I know that that's a lot. Nothing in this policy says that the doctor has to be your doctor who knows you, who has a history with you, or that this doctor has to be an expert or knowledgeable on your diagnosis or on your prognosis. And in fact, the Death with Dignity Center, one of the proponents of this bill, they suggest very helpfully on their website that if your primary care doctor doesn't believe in killing their patients, you might go to a dermatologist or a psychiatrist and ask them to write this prescription, because as a medical doctor, they qualify under this law. And then when you need a second doctor, they very likely have a colleague who would happily sign off so that you can practice your choice of having your doctor help end your life. So when they say there have to be 2 doctors involved, that's true, there do have to be 2 doctors, but they don't have to be doctors that know anything about you, about what you're facing at home, about what coercion you might be experiencing, about what pressure you might be experiencing. And that goes to the worst case scenario, the 10% of elder adults that we estimate experience abuse in this country. We know that not every family is loving, but even for the families that are, those people experience feeling like a burden. I know that my mom did, and I like to think that it's not because of anything that I did as her main caregiver. I like to think that it wasn't us as her family that made her feel as though she was a burden on us. But it's natural to feel when somebody has to provide extra care for you or provide a little extra work that is uncomfortable to receive. It's natural to feel like a burden. And so what do we as a culture, and in this room, people who support a culture of life, what do we do when somebody that we love is feeling that way? Do we provide them help and support, or do we tell them that we think they're right? Assisted suicide laws tell our most vulnerable friends and family that they are right and that they'd be better off dead. It changes the background noise for doctors of how they treat their patients, and it changes the expectations of family members when their parents get sick. In every state where this has been legal, we see consistently that every year people use it a little bit more and a little bit more and a little bit more. As it becomes more accepted, it begins to become more expected. What we see in Canada is that they have just run down the hill. It's an absolute avalanche there. So they started with a similar type of policy that we have, which is theoretically for people who have a terminal illness and a 6-month diagnosis. They went back and they amended their law, and they said, actually, anybody who has any disability should qualify, because if you have a disability, we understand why you wouldn't want to stick around. So understand when I say any disability, if somebody is partially blind, that will qualify them to go to their doctor and have their doctor end their life. These are our northern neighbors. This is a very civilized country. This is what's happening just across a border and what has become accepted practice there. Here in the US, we see attempts to expand the laws even further in the states where it's already been legal. Last year in California, there was an attempt to expand it for people with early onset dementia and to also allow for IV administration, which the law currently says you have to self-administer. And what I want you to understand about that is that there is the lead sponsor in California of the original bill who came out opposed to that amendment. And you might think, well, that's great. That's proof that this is working, right? That we're going to go this far and no farther. She didn't say it was a bad idea. She said that she was opposed because it was too much too soon, and pushing for too much too soon would jeopardize their efforts in other states. What we see in many of the states that have passed so far is that they come back later to try to expand the law even further. So they might start that it has to be a physician, and then they come and they amend it to say that it can be physician assistants, or it can be nurse practitioners, or it can be advanced practice nurses who prescribe lethal drugs. Let me back up for a moment and talk about that 6-month diagnosis. Does anybody in this room know someone who outlived a 6-month diagnosis? Yeah, that's a lot of hands, right? Doctors are notoriously bad prognosticators. My apologies to any physicians in the room. It's just not something that we're good at. The practical application of this policy, and you all are people who are going to be voting on this law or have influence on this law, so you have to understand the practical application of what happens when something like this is passed. There is nothing in the law that says you have to have exhausted treatment or that you even have to have tried treatment. It says you have to have had a 6-month diagnosis. Now, many people outlive that 6-month diagnosis. Again, doctors are bad prognosticators, which is good news if you get a terminal diagnosis. But because the law doesn't require that you have even tried treatment, what we see is that in application, people qualify for this if they would die within 6 months, regardless of if they have treatment. So with or without treatment. Now, there are a lot of conditions that if you don't receive care within 6 months, you will die from them. And that is why in Oregon, we see again reported from the Oregon Department of Health, diabetes has been considered a qualifying condition, because if you do not receive appropriate treatment within a 6-month period, it absolutely can be lethal. That's how a doctor justified in Colorado giving lethal drugs to young women in their 30s who had anorexia. Now, anorexia, as you may or may not know, is actually a mental health diagnosis. Mental health diagnoses are not supposed to be covered under either the policy that's been put forward in New York or the one that passed in Colorado. But because without treatment, anorexia can be lethal, that doctor justified her choice to prescribe these drugs to these young women. And what you should understand about that particular case is that as horrendous as it is, and as much as we're all shaking our heads and saying that's not how this is supposed to be used, we only know about it because the doctor reported it to a medical journal that she wrote a paper for about this great new practice of how to care for anorexia patients. Oh yeah, no penalty. No penalty for her. She still practices. This is the practical application of assisted suicide laws here in the United States. So think for a moment not just about the people you know who outlived a 6-month diagnosis. My mom was one of them, 3.5 years. But think about the people you know who require some kind of treatment within a 6-month period in order to continue living. And then think for a moment about the people that you know who require some kind of aid in living and have difficulty accessing that aid in living. And think about how they're going to be impacted and affected by this kind of policy. I want to be just cognizant of time here, make sure I don't go too over. So when we look at the safeguards that are put forward here under assisted suicide, and it is suicide, they really don't hold water when they're actually put to the test. There are a million ways, unfortunately, to abuse them, and these laws are written in such a way to make it incredibly challenging to investigate and incredibly challenging to prosecute. The reporting is done in a way to provide anonymity for the doctors and for the patients. So when proponents tell you that there have never been any abuses, I have to wonder if these young women with anorexia were flaws or features of how this policy should work. And what does that mean for everyone with a disability who already has an added challenge accessing any kind of equitable health care? Proponents will say that this is about a choice and that it's about autonomy. And I would question the ability to make an autonomous decision when everything in your life is pointing you towards one door. If your family is making you feel like you're a burden, if the cost of healthcare is weighing you down, if you think that everyone around you would be better off if you were just dead, and when your state and your society are agreeing with you by carving you out as an exception to the suicide prevention that everyone else receives, can this ever really truly be an autonomous choice? Or is it a gateway, frankly, for a lot of people to save money? And so for that, I'm going to go back into history a little bit, and we look at Compassion and Choices, which is, again, one of the main proponent organizations. And they were birthed out of the Hemlock Society, which has been very, very open. Oh goodness, I think it was the 80s that they were founded. And their position has always been that anybody, anywhere, for any reason, should not only be able to kill themselves, which unfortunately everybody already has that ability and that right, but that other people should be able to help you. And one of the founders of the Hemlock Society said at a point that people weren't responding well to the economic argument of why this should be feasible, and they really needed to start talking about suffering more to get people on board. So again, we're going to go back to what the Oregon report says, which is that people don't choose this for suffering. They choose it for reasons of disability, and they choose it for socioeconomic reasons. They choose it because they don't want to be a burden. That is why this is an issue that brings together our conservative allies and our progressive allies, because no matter your political stripes and your political ideology, we all have vulnerable people that we love, or we may find ourselves to be those vulnerable people, and we don't want the state to have a policy that puts us at further risk. This is inherently discriminatory when you carve out some people as deserving of a lesser standard of care. And there's no place in New York for this kind of policy.